it's good if we can start. I mean, whoever that wants to join the class should be able to make out time to be on, join class on time.
Yeah.
If we keep, yeah, but we are working against time. So,
Yes. I'm going to stop exactly 5. So we have to start. So today we'll continue by talking about bronchiectasis, and this is something we are already familiar with. So the basic problem in this condition is just permanent dilatation of the bronchi. That is what you are looking out for. Permanent dilatation of the bronchi, not even thickening, not thickening, but that dilatation. That's the word. Because you can have some other conditions that are not, you know, that is not bronchiectasis that causes thickening of the bronchi. For example, chronic bronchitis. Chronic bronchitis causes thickening, while dilatation of the bronchi is specific for bronchiectasis. So it occurs due to recurrent cycles of infection and inflammation. So you have bacterial infection triggering, um, inflammation, bringing about the, the presentation. So what we just need to know is just the 3 major pathophysiology of this. That is, what are the predisposing factors to this recurrent cycle of infection and inflammation? So 3 things we need to know. Number 1, bronchial obstruction and mucostasis. Number 2, anything that can reduce the level of immunoglobulin or any autoimmune condition. Number 3, past infection. The etiology of bronchiectasis falls within these 3 categories. These 3 categories will always explain the recurrent cycle of infection and inflammation that brings about permanent dilatation of the bronchi, causing bronchiectasis. So, um, okay, I think I have it here. Let me just, I'll come back to the etiology. So let's talk about the presentation. So what we are looking out for in an individual that has bronchiectasis is production of purulent, copious sputum. They have cough, they can experience cough, yeah, but you notice an increased amount of sputum production, and most of the time the sputum is very, very purulent. Yeah, increased production of um, sputum. It can have some coloration depending on the organism involved. With pseudomonas, with strep, E. coli, and the likes. So that can impact the color. For example, when you are seeing green, you want to think of pseudomonas. So they have this chronic cough with increased, that's why I said copious, with increased purulent sputum production. And of course, because of the fact that the inflammatory condition that is happening can also narrow the airway, that's why it's categorized as part of the obstructive lung disease. It can cause dyspnea and difficulty in breathing. Um, because of the foul smelling, mucus that they produce, they can have halitosis, and at the same time, the inflammatory reaction can be so severe that it can erode into the submucosa. We have the mucosa, the submucosa, the muscularis propria, and the adventitia. So the inflammatory response can be so vigorous that you have erosion into the submucosa. And remember that the submucosa contains the vessels. So from there, they can erode into the vessels and they can cause hemoptysis. But hemoptysis is not a common. It's not. Don't let me say it's not common, but it's not something that you see like every time. But if you see it, it further strengthens your diagnosis. So somebody having cough, production of increased amounts of purulent sputum with hemoptysis and halitosis, you have to um, have an heightened suspicion for bronchiectasis. So that is that. Now, moving on to the causes. So let's go back. We said bronchial obstruction and mucostasis, low immunoglobulin and autoimmune disease. chronic past infection. So for the bronchial obstruction, this can occur from things like foreign body, um, cancer eroding into the airway, like somebody having um, this bronchial carcinoma. What's the name of this last one? This one that, why am I forgetting the name of this? That has this endobronchial component.
You
Somebody remind me.
Cartagena?
Is it
No, no,
adenocarcinoma?
no, not adenocarcinoma. The last one that causes wheezing and then carcinoid symptoms. Is it bronchial or
Oh,
Bronchogenic.
no?
the bronchopulmonary
No,
aspergillosis.
that last one. Bronchioid. I think it's bronchioid. I will call it bronchial carcinoma. We have small cell and the non-small cell. The non-small cell, the squamous, the adenocarcinoma, the large cell, and that
Ah,
last one, the bronchial. I think it's bronchial. Bronchioid.
I think I know
Carcinoid,
what.
Include
carcinoid,
bronchial.
yeah, bronchial carcinoid,
Bronchial carcinoid
cancer.
tumor. That's
Yeah,
the one with the flushing, dizziness, diarrhea, and wheezing, right?
exactly. So that's what I'm trying to remember. So because of the fact that it usually has an endobronchial component, it grows within the bronchus. So it can occlude the bronchus. And what happens? You have stasis of mucus. Now that um, mucoidal stasis is a potential site for bacterial proliferation. So you have bacteria proliferating there, causing inflammation. Inflammatory reaction can get widespread, evade into the submucosa, causing all this presentation, the dyspnea, the halitosis, the noctusis, and of course the purulent um, expectoration of mucus. So bronchial obstruction from foreign body, from cancer, you can have mucostasis. Mucostasis from condition like cystic fibrosis. You are familiar with the pathophysiology of cystic fibrosis, they produce a lot of sticky mucus that can accumulate within the airway and, of course, potential site for bacterial proliferation. Individuals with allergic bronchopulmonary dysplasia, allergic bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, we are going to talk about it. They also have, mucostasis in them, and they can have bacterial ingrowing there and causing the inflammation. So this number one pathophysiology is very important. The second one is any condition that causes low immunoglobulin. So if you look at our immunology section, we'll see that some of those immunodeficiencies have bronchiectasis as part of their presentation. For example, an individual with severe combined immunodeficiency or IgA deficiency, those those conditions cause reduction in production of immunoglobulins, particularly IgA, which is the major immunoglobulin that helps to protect the airway. So if you don't have that immunoglobulin coverage, they are vulnerable to bacterial infection, can lead to inflammation, which can even become recurrent because you don't have anything taking care of it. So it becomes recurrent, causing widespread inflammation that causes permanent dilatation of the bronchial at the end of the day. Autoimmune disease, systemic sclerosis, SLE, rheumatoid arthritis, because in all these conditions, you have immune dysregulation. Your immune cells are supposed to be attacking the foreign bacterial antigens, taking them out and not doing what they are supposed to do. They are focusing on the self antigens. So that immune dysregulation can predispose to recurrent bacterial infection, causing, the inflammation leading to bronchial dilatation and damage. Then, of course, recurrent past infections. So somebody having TB, they can form cavities. These cavities can accommodate accumulation of mucus with superimposed bacterial infection, causing bronchiectasis. So we should not forget the first one, bronchial obstruction and mucostasis, cancer, foreign body, cystic fibrosis, allergic bronchopulmonary aspergillosis, any condition that causes immune dysregulation, and chronic past infection, like people that experience recurrent infection with pseudomonas, people that experience recurrent infection, maybe like tuberculosis, forming cavities, can lead to recurrent bacterial superimposed growth, leading to bronchiectasis. So this is the city finding of what you see. We talk about the tram lines that we see. We talk about the signet ring appearance. So let me just show us everything we are talking about so that we won't be lost. So, we've talked about the presentation, the cough, the sputum production, the difficulty in breathing out coughs, the hemoptysis and the halitosis. But we should pay attention more to the increased sputum production, the cough, and of course the hemoptysis too. These are the causes. So you have to take history of this condition. So does the person have any history of cystic fibrosis? We know what to look out for. Infertility, they can have pancreatic issues, diabetes, recurrent chest infection, rule out cystic fibrosis, and of course some past pulmonary infection like pseudomonas, just like I mentioned, mycobacterial infection, both the typical and the atypical, allergic bronchopulmonary aspergillosis. This is a very, very interesting condition which we are still going to talk about. So it just occurs due to increased airway hypersensitivity to innocuous aspergillus spore. A normal person that is immunocompetent will inhale aspergillus mode and the person will not have any reaction, any inflammatory response. But people that have some background conditions like cystic fibrosis and asthma, they are highly sensitive to aspergillus spore and they can develop allergic bronchopulmonary aspergillosis that can lead to recurrent, bacterial infection due to mucostasis because it triggers a very heightened inflammatory response. You can have a lot of mucus secretion there, bacterial superimpose, inflammatory response, damage to the bronchial airways. So allergic bronchopulmonary aspergillosis is a very, very good example of hypersensitivity causing um, causing bronchiectasis. So what kind of hypersensitivity do we expect from somebody? Just a guess from what I've explained. Allergic bronchopulmonary aspergillosis. What kind of hypersensitivity would that be? Anybody?
It's one now. One.
Type 1.
You still look like asthmatic
Yeah, it's
as
one.
asthma.
Type
Type
1.
one.
So immunodeficiency. We have talked about this. Somebody having severe combined immunodeficiency, somebody having IgA deficiency, all of them can, develop recurrent bacterial infection causing the bronchiectasis. Localized airway obstruction, we've talked about this. Somebody has foreign body occluding and is not even being removed. You can have mucostasis beneath that area, because there's an impairment in the clearance of mucus and bacterial superimpose, and you have your same with aspiration conditions. Then autoimmune, just like we talked about, the immune cells are not able to respond adequately. And the same thing also applies to inflammatory bowel disease. There's a form of immune dysregulation in some of those IBDs, like Crohn's disease, that lead to impaired immune response to bacterial infection, and you have superimposed, you have uncontrolled inflammatory reaction. So the common ones that they don't really talk about is IBD, but the common ones to look out for maybe you have a cancer, somebody has a cancer that's including the airway, or somebody has cystic fibrosis that is causing a lot of mucus secretion and mucostasis, or allergic bronchopulmonary aspergillosis, as well as immunodeficiency. So those are the common ones that they test, you know, for bronchiectasis. So what do we see on examination? We definitely know that this is associated with a lot of mucus production. So this person will expectorate a lot of purulent mucus, just like we see here. We can see the word. Thank God that the word is here already. Occasional hemoptysis, depending on the severity, because you can have some that is not very severe and they don't present with hemoptysis. So hemoptysis is not a rigid finding that you must see before you make your diagnosis. So occasionally, depending on the severity, they can have hemoptysis, and of course, very constant purulent mucus. Because of the fact that it is part of the obstructive lung disease. You have obstruction of the airway, and of course, the person can experience wheezing. You notice person has wheezing. You hear and when you listen to your chest, to the person's chest, you hear ronchi. So wheezing, ronchi, they are like same thing, and because of the inflammation and the likes, you can hear crackles. Which is the rails. So um, those examination findings might not be specific, but from the history, you can pinpoint the possible cause, and of course, you want to confirm your diagnosis with some imaging test. So you can do your chest X-ray initially, but that is not the definitive investigation modality. So initial test, chest X-ray, what are you going to see? Increased bronchiovascular marking. So this increased bronchiovascular marking is just reflecting the increased airway inflammation, particularly within the bronchial. Of course, you know that pulmonary vessels are going to run side by side with the bronchial walls. So you have recruitment a lot of white blood cells from those vessels into the bronchial airway, so they can increase the bronchiovascular markings. I don't think we need to really stress ourselves and be looking at X-ray to be looking at bronchiovascular markings. Nobody's going to tell us that. They can mention it in the question stem that X-ray reveals this, so that it can guide us. They are not that wicked. Don't expect us to be radiology experts. There are some conditions that they might be rigid. That definitely you need to know the way it looks like on imaging, but not something like increased bronchiovascular marking. So maybe on CT, maybe CT findings, because CT findings are more detailed than X-ray. So you must be able to identify CT findings of most of the conditions. So, and of course, the tram lines. The tram lines are just parallel lines that is showing the dilated bronchial from the recurrent inflammation. So the specific one and the most important one is the high resolution CT scan. You must definitely do a high resolution CT scan to make your diagnosis of bronchiectasis. And what are you looking out for? Dilatation of the airway, which is a major problem. The airways becomes dilated. And what happens? What do you see? I don't know if I think I have some image that I've pinned here for us. Yeah, so I think this should be like a coronal section of CT showing lung. So we can see the black area is talking about the air, right? The black area is air, abi, while the surrounding white stuff is the blood vessel. So you have the bronchial wall surrounding pulmonary vessel, or the bronchial vessels, so the bronchial wall and the surrounding white vessel. So you will notice that the caliber of the bronchial wall is wider than that of the vessel. That should not be. That should not be. You can see this. This is bigger compared to the surrounding vessel. This one still looks alright, but most of them appear bigger than the vessel. So this is what we call the signet ring sign. So it looks like a signet ring in which you have the diameter of the bronchial wall being bigger than that of the surrounding vessel. Ideally, they should be equal when there's normalcy and there's no bronchiectasis. Another thing you notice is that there's failure of distal tapering of the bronchial. Normally, as you move downwards, you expect the bronchial wall to get narrow and taper down. But because of the concurrent and the continuous inflammatory damage, you notice that everything becomes widening throughout. And at the end, you see some outpouching, some cystic component at the end. So this, like this 60 here, 60 here, 60 here, 60 here. So like ballooning. So those three things can help you. You dilated, airway, just like we can see, dilatation of the airway, and also, of course, the signet ring sign, which is, the airway being larger than the surrounding pulmonary vessel, failure of the distal tapering. So those are the cardinal signs, just like we have here. You see, dilated airway that is larger than the surrounding pulmonary artery and habituated signet ring sign, the balloon cyst at the end of this bronchioles, most majorly at the lower lobes. So let me see what I have here. I don't know. Okay, I think this is X-ray finding. Oh, this is not X-ray. This is still CT. Okay, we can see here very well that this one is bigger than this. You can see that the airway is greater than the lung, the pulmonary vasculature. So that's in keeping with what we have in bronchiectasis. So, oh, I forgot to mention this condition. This is very, very important, cause of bronchiectasis too, that many people don't put mind, And what do we see on spirometry? What do we see on spirometry? Of course, you are going to see the obstructive pattern, and we don't expect this one to be reversible with our SABA. So we don't expect it to be reversible with asthma, just like we have in asthma. And the obstructive pattern is just FEV1 by FVC ratio less than 70%. So that's our spirometry finding. Once we do our CT, we get our result, we are okay. So, but these are the associated abnormality that you observe. So, what are the other additional tests to narrow down the cause of the bronchiectasis? Because bronchiectasis is just like a presentation. You have something that is causing it. So, you can basically, most times on clinical suspicion, you see the other associated presentation. But to help you, you can do some other tests like, doing sputum microscopy culture to identify any chronic infection that might be recurrent in that person. Maybe the person has been recurrent pseudomonas, maybe due to one background immunodeficiency like that, current E. coli, or tuberculosis, just like we have here. Your sputum culture, microscopy culture, and sensitivity can help you identify the implicating organism if there's an organism. And also, it can also help you make diagnosis of allergic bronchopulmonary aspergillosis because you can culture aspergillus organism and maybe using Sabarodega, and you can narrow down the cause of that bronchiectasis. And of course, there are some additional tests that also raises suspicion for allergic bronchopulmonary aspergillosis, which we are still going to talk about very, very well. So, because it's part of those eosinophilic pulmonary syndromes. This is an allergic condition, so you expect the person to have high amount of eosinophils in the sputum. So you check the sputum, you notice that about more than 25% of the white cells within that sputum contain eosinophils. So that can raise your suspicion for an allergic process happening. And of course, you can see the hyphae by the time you do your what's it called, your biopsy, or you do your sputum analysis, staining, you can see this hyphae branching at 45 degrees. So you can alpha 1 antitrypsin, thank God I highlighted it, is also very, very important. It's an important cause of bronchiectasis because it can also damage the airway. Yeah. So many of us just know, okay, alpha 1 antitrypsin causing emphysema, causing um, hepatocellular carcinoma at the end of the day, liver and lung pathology. But there's more to the lung pathology aside chronic bronchitis, or sorry, aside emphysema. The alpha 1 antitrypsin, because this guy normally is located in the airway to protect us from neutrophilic damage. So the neutrophils usually come around and they have this enzyme that we call neutrophilic elastase. And if somebody has a low level of alpha 1 antitrypsin enzyme, this individual will not be able to inhibit the activity of this neutrophilic elastase. So you have unopposed activity of the neutrophils releasing their elastase, and they will damage the elastic fibers within the bronchi. So you will notice that the bronchi will become permanently dilated because of the fact that they are not elastic. They don't have that recoil tendency to move inward toward themselves. So they start widening it like they are compliant. So start getting bigger. So when you have alpha 1 antitrypsin deficiency causing problems within the bronchial airway, that's tilting towards bronchiectasis. When it affects the alveoli, then you can talk about emphysema, the pan-acinal form of emphysema, which we are going to talk about. So that's how much your gram stain MCS can, your sputum MCS can reveal infection, including aspergillus, and of course you assay for the level of alpha 1 antitrypsin. Very important. And you want to do your sweat chloride test, to rule out, or genetic testing to look for the mutation experiencing cystic fibrosis, that's phenylalanine mutation of 18, causing the cystic fibrosis transmembrane, you know, um, uh, receptor protein mutation. So once you identify that, you can narrow it down to cystic fibrosis. And because of the other autoimmune conditions that can lead to bronchiectasis, you might want to do, analysis of some of those antibodies. Like you want to check for anti-citrullinated peptide, for rheumatoid arthritis, you want to check for rheumatoid factor, you want to check for HANA, you want to check for, sorry, excuse me, you want to check for topoisomerase, scleroderma, just those autoimmune, depending on the clinical presentation. So aside the bronchiectasis, what else is the person having that you think might explain that increased production of purulent sputum, that cough, the the wheezing and the hemoptysis. So that is that about the additional test. But the most important test to do is your high resolution CT scan. That's going to help you with your diagnosis. So we have a question here. A 10-year-old child with a history of asthma on daily fluticasone has been using albuterol inhaler once a day as needed for several weeks. What changes should be made to this current regimen? What do we think? Daily fluticasone, uh, yeah,
You can
symptoms once a day.
mm,
So what do you think?
he's you need to move him up a bit, so probably move him to step 3.
Nice. So
Mm.
what are we going to
Mm.
give him?
So you give him more of ICS and maybe probably Laba, sorry.
Yeah,
Laba, any of those, Meterol or Laba, any of them.
yeah. So this guy is only
Maintain.
on fluticasone. He's only on
Mm.
fluticasone. So the maintenance fluticasone, that's not enough. You need to add your LABA to it.
Mm.
So LABA plus your ICS daily. That's what is going to help that individual. Okay. Thank you, Dr. Joy. So for the treatment of bronchiectasis, what are you going to do? What you just need to do is just to take care of what is happening. And what is happening, you know that majority of the time you have bacterial infection or fungal infection causing the problem. So you want to give antibiotics first, or you want to give antifungi. And of course, you are also going to give steroids to limit that inflammatory drive that is happening. So you give antibiotics for the exacerbation to reduce the bacterial load and the consequent systemic inflammation. So antibiotics very, very important. Even before you take your sputum for analysis, your culture and sensitivity, you should place an empiric antibiotic, the respiratory fluoroquinolones, which is your level and your moxie. Very important. Before you take your sputum culture, you will have administered your level and your um sorry after you take your culture, rather, you give your level and your moxie, which are your empiric treatments. Then you look at whatever organism is causing that condition, and you can now switch to the appropriate antibiotic to take care of that organism. But if it's the case of allergic bronchopulmonary aspergillosis, even one thing that is going to raise your suspicion for this guy is that by the time you see the person having asthmatic symptoms, wheezing, chest pain, chest tightness rather, wheezing, the cough, and you are giving antibiotics and it's not working, you know that this is not likely to be maybe bacterial causing stuff. So you want to investigate further, which I'm going to talk about later. And at the end of the day, if you are able to find out that aspergillosis is what is responsible, you might want to give antifungal. And the ones that are specific for aspergillosis, you want the voriconazole, and of course the common one, which is itraconazole. You can use any one of them, and you have to combine with glucocorticoids, just like what you do for bacteria. So the two common thing you have to do is just your antibiotics or your antifungal with your steroids. That is all you do. And of course, because of uh some the other presentation, which is the call of the mucus production and the likes, you can also want to help with the drainage of the mucus. So there's something you do, which includes your chest physiotherapy. You can encourage um, incentive spirometry, blowing air to facilitate the mucus drainage. Sometimes you can do chest percussion. You can position them in some certain position. There are a lot of positions that they put them just to allow gravity help with the drainage process. You can give expectorants to promote cough so that they can bring out those mucus clogging the airway. So cough promotion to drain out the mucus. You can position them in some certain position that allows with mucus drainage. You can, do chest physiotherapy, intensive spirometry, and of course, you can also give some drugs like hypertonic saline, Donis alpha. All these drugs are like mucolytics that helps um, with with the drainage at the end of the day. So that's just encouraging bronchopulmonary hygiene. So cough promotion, expectorant, postural drainage, chest physiotherapy. So sometimes there might be need for surgery. Sometimes there might be need for surgery, particularly in severe cases where there is hemoptysis. You might need to go in to remove that particularly affected lobe of the lungs. So you are trying your treatment, it's not working, you've done all these things, lifetime modification, giving you antibiotics, giving your steroids, it's not still you know, resolving. You might want to remove that affected segment of the lung. That is lobectomy. Sometimes you might also want to remove, maybe when there is uncontrolled hemorrhage from the hemoptysis. The hemoptysis can be so bad sometimes that it can be uncontrolled. So you might want to, you know, remove that lung zone, and of course, a long time, encourage lung transplantation so that the person can go back to normalcy, particularly when it's really, really very, very bad. So that's that about the management for bronchiectasis. So you should not forget your antibiotics or your antifungal with your steroids, encouraging lifestyle modification. You can place them on some certain position to facilitate mucus clearance. You can give mucolytics. You can give expectorants to allow for cough production and chest physiotherapy. Then in severe cases, lobectomy or definite lung transplantation to solve the problem once and for all. Um,
Okay,
so
so Dr. Baba, so what do you mean like by
spirometry.
incentives? Yeah.
There's this thing, I don't know if you remember, people that do surgery, there's this thing that they blow. They tell them to be blowing. All those things can prevent the lungs from collapsing, can also facilitate mucus drainage. Do you know? Let me show you the picture of what I'm talking about. I don't know if anybody knows what I'm talking about. They look like, they have like tiny balloons, small, small like this. It's like a toy.
It
This.
looks like by itself. Yeah, it goes up and down.
Exactly. So tell them to be
The
blowing it.
blood goes up
And
and down.
yes. So people that go for surgery to prevent post-operative atelectasis, you tell them to do this, and it also helps with mucus clearance too at the end of the day. So, Dr. Antonia, do you get that now?
Yes.
So
So
that's the form of
basically, yeah, okay. So kind
so
of
that's
they do it to help with drainage of the mucus.
mucus here. So it's a form of chest physiotherapy. It's a form of chest
Okay.
physiotherapy.
Oh, okay. Then, so
Yes,
this bronchiectasis is all about recurrent infection and inflammation.
inflammation. Yes,
That
and you remember
because
the.
by Mhm.
I'm listening. I'm listening. I'm listening.
Yeah, that can be caused by a lot of factors. So that,
Yes,
like in summary of all you say, just recurrent infection and inflammation caused by, it could be obstruction to the airway, infection, or autoimmune inflammation, autoimmune diseases.
exactly. So once you have that already arranged in your mind, you can now fix it. Okay, which ones will be
Which one?
airway obstruction, which one will be
Mm,
mucostasis, which one will be immune problem, which one is going to be infection. So,
mhm.
so that's the way it is.
Okay. And the screening test or like the laboratory investigations to be done depends on what you find out from the history. I mean, you're not going to do
Yes,
all these laboratory investigations. So you tailor
yes,
it down to whatever you find out. I mean, a
in the
pointer
history,
in your history.
definitely, definitely. So you already know what is likely you are going to say in someone that has cystic fibrosis. You know
Mhm,
what is likely in someone that has lung cancer. You know
mhm,
what you are going to find in someone that has rheumatoid arthritis, SLE,
mhm,
alpha 1 antitrypsin.
mhm,
So the person might be having, emphysema presentation, might be having liver problem. So definitely you are going to get TB, weight loss, chest pain, history of travel to one place, night sweat. So you definitely get something that will raise your clinical suspicion for the underlying cause from the history.
Mhm.
So COPD. So COPD. Let me see. I think I have some questions before we move. Okay. So yeah. So a 49-year-old woman comes to the office due to coughing up blood. The patient says she's always sick. Okay,
Sorry, is it
expansion.
able to expound it a bit? Yeah, thank you.
Ex- expansion. Is
Yeah,
it
that's
better now?
yeah, thank you, thank you.
A 49-year-old man comes to the office due to coughing up blood. The patient says she's always sick with a chest cold. She reports chronic cough with daily production of copious, thick, yellowish mucus that has gradually worsened over the past 10 years. Recently, the sputum has been sticked with bright red blood. On few occasions, she has expectorated more blood and mucus. Medical history includes several episodes of bacterial sinusitis and lower respiratory tract infection. The patient currently takes no medication other than guanfacine as needed and an antacid for occasional heartburn. She has never smoked cigarettes and rarely drinks alcohol. Temperature is 36.9, blood pressure is 112, pulse 81, respiratory rate 16. The nasal passage are clear, the sinuses are non-tender. Cardiovascular examination is normal. Lung auscultation is notable for coarse, wet biphasic crackles diffusely that improve after coughing. Skin examination is normal. Which of the following is the most likely cause of this patient's hemoptysis? So, what do we think? Well, the stuff is already like spelled out
The
already.
answer is looking at us now.
What? So, yeah, the answer is already
Bronchiectasis.
looking at. So, bronchitis.
Bronchiectasis is A.
Yeah,
It's
yeah,
Yeah.
bronchitis.
this is bronchitis. So, what do we think is a predisposing cause of this bronchitis?
It was a long history.
Infection.
Yeah, you can see they
That's
said several medical
Mm-hmm.
history includes several episodes of bacterial
some
sinusitis, and so that's
Mm-hmm.
the cause in this case. Okay. Um, number two, a 24-year-old man comes to the office due to worsening productive cough with tenacious sputum, fever, shortness of breath for a week. Um, today he noticed, please, the word tenacious, copious, that's what it means too. So today he noticed blood sticks in the sputum. The patient had several similar episodes in the past, and symptoms usually improved somewhat with antibiotics but never went away completely. He also has decreased exercise tolerance, fatigue, and weight loss. The patient does not use alcohol, tobacco, or illicit drug. There's no family history of similar problem. Temperature is 38.9, blood pressure is 130, pulse 102, respiration 20. Examination reveals crackles in both upper lung field and heart sounds are normal without murmur. The patient abdomen is soft, non-tender without organomegaly. Digital clubbing is present. Leukocyte count is this 15,000. Chest X-ray reveals a right upper lobe infiltrate and a sputum glue pseudomonas aeruginosa, which of following is the most likely underlying cause of this patient's current symptoms.
can't even see. This thing is so tiny. I'm straining my
And
eyes.
I'm struggling. I'm struggling.
let me let me see. Well, this one is not really the typical one to
Dr. Wale, can you bring? Yeah, that's what I
It's-
want. Yeah. So they said, okay. Hmm. So we are sure the patient have infection as a result of Pseudomonas, right?
Mhm.
yes.
So we can try ruling out the options there. So now the question is asking the most likely cause of the patient current symptom. So we can rule out the causes here. So first of all, he is 24.
Okay.
Um, if we let's take out
So
A.
what's the history itself? I just want to understand what the history is saying.
Okay, the guy had productive worsening productive cough. That was this copious sputum. He has fever, shortness of breath for a week, and
Never
he
me.
yes, and hematitis to which he had little blood stakes in the sputum, not consistently, I think. So they said there was the symptoms usually improve somewhat with
I
antibiotics.
think this patient has CF.
It's cystic fibrosis, obviously. It's
Yeah,
defective chlorine because of we said cystic fibrosis. There are four, is it three? For Dr. Babal and Dr. Festus smacked me from my head. The three bacteria that are very notorious for cystic fibrosis. Staph
yeah,
aureus,
that's why the CF.
yeah, Staph aureus, Pseudomonas, and the Buca,
Mhm.
Bodifera guy, the Bodifera one for
Burkidoria,
Orchid,
Cepacia.
Buckyderia,
orchid.
that's it.
Mhm.
Buckyderia. So for
So
when
this patient has CF. So
CS,
the answer should be C, defective
yeah,
chloride.
it's chloride.
Yeah,
A will be
And
because
that's what caused the recurrent infection that, I mean, has
exactly,
received antibiotics and it's not really going away. It's
exactly,
exactly,
not
exactly.
going
exactly.
away.
So,
And
and of
so the
course,
recurrent stasis, fevering, recurrent infection.
Yeah.
Yeah.
No, that thing
yeah,
makes sense. A will be of emphysema or
exactly.
any disease,
Even
complement disease.
yeah, exactly. Even if somebody doesn't have idea, you can't make a spot diagnosis. Just go through the option and try to fit
Yeah,
in what is going on
Mm-hmm.
to that presentation. That can help.
yeah,
So because
Mm.
the major clincher here is just maybe the fact that person has upper lobe infiltrate that grew pseudomonas. I know that someone that is 24-year-old that is having pseudomonas, it's likely to be cystic fibrosis and the stuff is not even going. So cystic fibrosis. If this person was younger now, you might be thinking the person will have staph aureus
So,
causing
yeah.
the recurrent chest infection. So that's another angle where how the question can come.
Mm.
So I think those are the two questions I have. I think this should be the hardest. The other ones they are very straightforward. You don't even need to rack brain too much. You just see it, see the presentation, you pick your answer, you move. So bronchitis is very straightforward most of the time.
Mm.
So moving on to chronic
Sorry,
obstruction.
Titones alpha is a mucolytic.
Yes,
Yeah.
yes. It
Mm.
breaks down the DNA of the cells within the mucus.
Mm.
So that's what it does. So
Mhm.
they will now become less viscous at the end of the day and you know they will be flowing out. So that's how it does that. You use it in cystic fibrosis, if you remember a lot. You use it to treat people
Yeah,
with cystic
yeah,
fibrosis.
I know they use it a lot because I worked in CF clinic, so they use it a
Okay.
lot.
Which clinic?
So CF clinic, clinic
So
Okay.
what
fibrosis.
did you say,
Wow.
Dr.
Wow.
Babad?
I worked in the
Uh
clinic, so there are a lot of this
Mokol.
bronchiectasis. In
Okay.
fact, when I was there, there was a patient. We lost that patient finally, and he died from bleeding, from what the wife was telling us. She started coughing
Hey,
off copious blood and everything. So
that's the problem. So
that's
some
the
time,
problem.
even if the country that is well developed now, they can do maybe embolectomy. Sorry,
Yeah,
embolization, broken embolization to quickly arrest the bleeding temporarily. But in
yeah.
Nigeria,
I think he died at home, sir. The
eh,
man, he got so tired, from what the wife was saying. He was like, he gave up even before he died.
yeah, that's very
Dr.
sad.
Babad, what did NS alpha is used for?
So like donors alpha will cause lysis of DNA of the cells within the mucus. So
All
when
right.
it destroys the
Mm,
DNA, the cells are no longer there. Then the viscosity reduces, so you can easily drain out the mucus. So that's the way it works.
okay, thank you.
COPD, COPD, you're welcome. COPD. So COPD is just like asthma too. It's a disease that causes reduction in lung function with associated airway obstruction, particularly at expiration. So that's what we need to pay attention to. Lung function is reduced due to airflow obstruction at expiration, just like asthma. So it's very important we understand that. And we have two phenotypes. One is a clinical diagnosis, the other one is a pathologic diagnosis. So the clinical diagnosis is chronic bronchitis. So they can present in two different forms. You can have individuals that will have chronic bronchitis. You have individuals that have emphysema. So I think the commonest one, or the commoner one out of these two, is emphysema. So for chronic bronchitis, the clinical parameters that you are watching out for is production of presence of productive cough for more than 3 months per year for 2 years consecutively. So the person must be having um productive cough every 3 months, like not every 3 months, like for 3 months in a year. Then the following year too, the person will have that kind of presentation. So 3 months now, this year, next year again, 3 months cough like that. So anybody that has that, you can conveniently say that this person has chronic bronchitis. And I must mention that the commonest cause of chronic bronchitis is smoking. So once you are seeing the history that somebody is smoking and having all this kind of presentation, you should have COPD at the back of your mind, particularly the chronic bronchitis form. Why the emphysematous form is pathologic. So you might not really make the diagnosis from your history because they might not really present with productive cough. Their own problem is not actually with excessive mucus accumulation. Emphysema is different. So that's why their cough might be dry. So what is causing the problem in emphysema is when you have destruction and dilatation of the respiratory structures, that is the respiratory unit, structures that are distal to the terminal bronchioles. And that's, I'm sure we remember that from our anatomy. So what are the structures distal to the terminal bronchioles? The 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 two structures. Anybody remembers? Even though we know revise our anatomy and our
Alveoli,
step one.
the alveoli,
The alveoli,
the
yes. What else?
respiratory
Mm-hmm.
bronchus and
Yes,
We
alveoli.
have the
yes.
alveolar sac and the respiratory bronchi. Those are the respiratory
Exactly.
zone, guys.
Exactly. So the respiration zone, guys, which include the respiratory bronchioles and the alveoli, particularly the alveoli, that's what is destroyed and dilated in emphysema. So, and we have two pathophysiological cause of this destruction. So it can either come from smoking or alpha 1 antitrypsin deficiency. So they have different patterns. So if it's coming from alpha 1 antitrypsin deficiency, we call it the panlobular pattern. That is, you notice that the alveoli that are destroyed are the ones that are located at the distal portion of the lungs. So I don't know how we can code that. I'm not very good with coding, but maybe fry pan, the bottom of the fry pan or something. I don't know. So panlobular means bottom, the bottom of the pot. That's panlobular. Why smoking centrilobular is not central, it means the upper part. That is it, upper part of the lung zone. So the alveoli that is concentrated within the upper part, that's what is mostly destroyed in an individual that is smoking. While for alpha 1 antitrypsin deficiency, it is the panlobular distribution, which is at the basal aspect. So, what do we have here? In patients with COPD and chronic hypercapnia, excess supplemental oxygen can decrease. Yeah. So, because people with COPD, most of the time, they are kind of weak. You see, one thing that I'm still going to talk about the symptomatology. So, I just want to be showing us and saying it so that it will be very easy to remember. But one thing we have to remember about them is that they have exertional dyspnea. They can have cough, and you usually get history of exertional. They are tired. They do small work. They are already panting. They are tired. Exertional dyspnea, cough, very common in them. And because of that exertion, they don't hyperventilate like you see in the individuals with asthma. That, that even when you don't see the hyperventilation again, you know that there's a problem and you want to consider intubation. No, here they are kind of tired every time. So what do you expect for the level of CO2? The level of CO2 increases. So they have this chronic hypercapnia in them. That's even their stable stuff. So the elevated CO2 has even dampened the central respiratory drive, that it doesn't even provoke hyperventilation again, because when it gets elevated to a certain level, dampens the central respiratory drive and it doesn't um, provoke hyperventilation again. So um, um, if you now administer supplemental oxygen to them, the brain might interpret that as them having excessive oxygen. So it will even further dampen that respiratory drive and can worsen the hypercapnia and can cause respiratory acidosis. That's why you are very, very careful with giving um, oxygen in people with COPD. You don't want to give high amount of oxygen and overshoot it beyond the requirement. You keep it between like 88 to 92%. So we give them more than 92% to further decrease that drive, and the person will have worsening hypercapnia and respiratory acidosis because they are already in a chronic hypercapnic state. So don't give high too much level of oxygen, saying you are trying to help them with their dyspnea and hypoxemia. You can tilt them to hypercapnia and they can present with respiratory acidosis. And this hypercapnia is so bad because you can have hypercapnic encephalopathy. So you notice that the person becomes drowsy, becomes dizzy, confused, can even have seizures and cerebral edema. So that's why hypercapnia is a big deal in people with COPD. So you just leave them in their stable hypercapnic state. Don't overshoot it by giving
Okay, so
excess.
there's something you said about this hypercapnia I missed.
Okay.
There's something I don't know, but it said it can cause them. I missed it.
Yes. Don't worry, we'll still get it. I'll talk about. I just saw it as key fact. Just said, let me just talk a little bit about it. So what I'm trying to say
So
is that
you can give them oxygen between 88% to
to
96%.
92, to 92, to 92.
92.
Yeah. So if you take it more than that level, it will further depress the ventilatory drive. So they can now have, a more worsened hypercapnia, and it can trigger hypercapnic encephalopathy.
Oh
So
yeah.
just notice that you see it in the question stem. The person is having something looking like COPD and they gave oxygen. They raised the oxygen level to like 96. Then suddenly the patient becomes drowsy, confused, started having seizures. That is hypercapnic encephalopathy straight up because you have further reduced the already dropped ventilatory drive, causing respiratory acidosis and worsening the hypercapnia. So let us move. So you want to consider alpha-1 antitrypsin deficiency in a patient that is less than 60 years. We already know this from our step 1. This is straightforward. So alpha-1 antitrypsin can cause both liver problem and lung problem. So the liver problem because alpha-1 antitrypsin molecule can, uh, um, because what is majorly responsible for that deficiency is that you have misfolding of that protein. There's a form of abnormality in its production. So it becomes misfolded, and that misfolded protein can deposit in the liver, causing liver problems, which can even progress to liver cirrhosis and eventual hepatocellular carcinoma. Then in the lungs, they are not available to checkmate the activity of the neutrophilic elastase, and your neutrophilic elastase is just there swimming towards the alveoli, destroying the elastic fibers surrounding the alveoli. And when the elastic fibers surrounding the alveoli are gone, there's nothing like elastic recoil. Please, we have to remember that in the expiration phase, what is driving expiration is elastic recoil. We don't have any muscle that we use. Expiration usually is a passive process. You don't usually use any muscle unless maybe things are getting bad. Ideally, it occurs on its own, and that is because the lung have elastic tendency. Please just picture that you have a rubber. If you stretch a rubber, you know that the rubber is coming back to itself. That is elastic recoil. It comes back to itself, generate an upward positive pressure that will move air out. Now, let us look at what will happen in someone that has COPD. Somebody has alpha-1 antitrypsin deficiency. The person is already having the liver issues. The alpha-1 antitrypsin is causing neutrophilic elastase to be destroying the elastic fiber within the alveoli. Do we think at the end of expiration that alveoli is going to recoil and come back to itself? No. And when the alveoli does not recoil and come back to itself, at the end of expiration, or not at the end of respiration, during expiration. It means that you are going to have air retention after you inhale, because you cannot move that air out by elastic recoil of the alveoli. So they get trapped during expiration. That's why when you see somebody that has COPD, they spend a lot of time in the expiration phase. They spend a lot of time trying to bring out the hair. Please hope you understand that little analogy that I've explained. Is it clear to us?
Yes.
Okay. So for alpha 1 antitrypsin, they have the liver problem. You see elevated AST, ALT, jaundice. Then they have emphysema, easy fatigability, the cough. You will definitely get no history of smoking, or the smoking history might not be significant, and the person will be very, very young, less than 60. And of course, the liver disease and a family history, because it's genetic, so they can inherit it from generation to generation. And we know the distribution of the alpha 1 antitrypsin deficiency causing asthma. We know the distribution. We have said it already. If it's smoking, it is up. If it's alpha 1 antitrypsin, it is a pan. PAN. P, pan, alpha 1 antitrypsin A. So the bottom of the pan, basal, predominant COPD. That's what you get. So a young person, liver issues, lung issue, no smoking, family history, alpha 1 antitrypsin deficiency. So looking at the phenotypes again, emphysema is the first one. We call them the pink puffers. Why? Because people with emphysema, they look skinny, lanky. They are kind of skinny. They're kind of tall. See them, they are slim. Don't let me say tall, because it depends on the person. The person might be short and have emphysema, but the common thing to all of them is that they'll be thin. And why? Because they don't have, is either they are smoking or they don't have alpha 1 antitrypsin. And because smoking too can also trigger neutrophilic recruitment. So your neutrophils will come to the airway from being attracted by the smoke, and the neutrophils will release elastase that is going to destroy the elastic fibers in the alveoli. So at the end of the day, you have a terminal airway destruction and dilatation common to both of them, both smoking and alpha 1 antitrypsin deficiency causing emphysema. And we know that when the elastic fibers is destroyed, there's no way the lungs can recoil during expiration to bring out air. So that means you have an expiratory obstruction. There'll be tearing of the airway during expiration, and you have a lot of air being trapped in the airway at expiration. So what did they do? You notice that many people with emphysema, they have this pulse lip appearance of their mouth. They position their mouth as if they want to, uh, pronounce choco. You should just do a mouth, you want to pronounce choco. So their mouth is kind of protruded like that. And what they do with this pulse lip positioning of the mouth is that they try to inhale. They inhale through their nose and they exhale slowly with their mouth. Now, that kind of positioning increases a positive pressure, creates a positive pressure in the airway, widens the airway, and allows for air to move out during expiration. So it's a form of compensatory mechanism. But that position usually involves recruitment of some certain muscles. So at the end of the day, the work of breathing is kind of increased. The energy expenditure is increased, and that is why they look wasted, because they continue doing this for a long time. And the work of breathing increases, energy expenditure increases, leading to weight loss. That's why you call them the um the sorry, not that's not the reason why they call them the pink puffer, but that's why they look skinny. Now, the reason why they call them the pink puffer is that they don't have hypoxia at the early stage. So they have, because of this mechanism that they're doing, so they can still get out the hair minimally compared to people with chronic bronchitis. So they don't have an early onset hypoxia. So they will look pink. So they have late onset hypercapnia, late onset hypoxia. So they look pinkish. So let us look at So, well, although I don't think in the question stem they will give us image of the individual, but just for clinical understanding, pink profile just to see. Look at, yeah. So this is an individual. You can see this person now, looking wasted and thin. Unlike chronic bronchitis, that person will look bluish and chubby. So let's go back to what we have in chronic bronchitis. So in chronic bronchitis, they are called the blue bloater. What is the problem there? They are smoking. They are smoking a lot. The smoking stimulates hyperplasia of the goblet cells. You have a lot of mucus production, occluding the airway. Just a summary. A lot of inflammatory drive from the smoke, release reactive oxygen species, triggering inflammation as well as hyperplasia of the goblet cells, secreting a lot of mucus. So that's why their own cough is productive. That's the first thing. And that obstruction is going to cause hypoxemia, right? So because of their own hypoxemia and they don't have any adaptive mechanisms, they don't do any pulse sleep. Pulse sleep no if you even help them because the airway is already narrowed by mucus. So there's no unless they bring out that mucus. So because smoking spoils the ciliary machinery, smoking generates a lot of reactive oxygen species that will lead to inflammation and hypersecretion of mucus that occludes the airway. So definitely they are going to have early hypoxia. And we remember that what happens to the caliber of the pulmonary vasculature in somebody that is hypoxic? Anybody remembers?
Sorry,
Sorry,
what's the
can you come
question?
again, Doctor?
What happens to the caliber of the vasculature in an individual that is hypoxic? What does the
It
vasculature?
is
It becomes narrowed.
Vasoconstriction.
it
Yeah,
constricts.
So there's
narrowed.
hypoxic vasoconstriction. That doesn't happen anywhere in the body. It is only in the lungs because they are trying to
Mhm.
shunt blood to the well ventilated area. That's what they are doing. So the other areas be dilated so that they can get more blood flow. While that area that is hypoxic, that doesn't have air, will undergo vasoconstriction. And at the end of the day, what do you think will happen? Right heart failure can happen from there. You have fluid pulling up in the right side of the heart, down to the extremities, the legs, the abdomen, everything, they become big. So that's why you notice people with chronic bronchitis look overweight and edematous because of this early hypoxia that they experience. So they are baby. So that's just explaining what you have. So what is the classic symptoms? Now, they have barrel chest. Barrel chest just means you have an increase in the anterior posterior diameter of the chest wall. This is very, very common in individuals with emphysema. You can also see it in chronic bronchitis, but it's very, very common in emphysema. You see anterior posterior diameter increase. They are using their accessory chest muscles to breathe to get more air. Because of the hypoxia, particularly people with chronic bronchitis that have early hypoxia, you notice that they have jugular vein distension because of the pulmonary hypoxia causing pulmonary vasoconstriction. So you have an increased afterload against the right ventricle. So fluid will start pulling up in the right ventricle, the right atrium, and of course the jugular vein. So you notice that they mix everything together because it doesn't really separate one from each other. It can be a mix. It can be a mix. So end expiratory wheezing. Yeah, you notice that it is when they want to take out air during expiration that the problem occurs. They don't have inspiratory wheezing. They have expiratory wheezing. Expiration when they are supposed to bring out air because of that obstruction, they start having noisy breathing and dyspnea on exertion. Very, very common symptomatology. Dyspnea on exertion. The muffled breath sound or distant um, heart sound or breath sound. Like the heart sound will sound very distant, the breath sound will sound muffled, as if it's faint, that you can't hear anything. This is this is from the hyperinflation that they have. You have a lot of air being trapped in that lungs, and it kind of dampens the sound. You can't hear much very well. So that should also raise your suspicion for um, COPD. So an individual having cough, having dyspnea on exertion, dyspnea on exertion. They give you the X-ray, you see the barrel chest, increased anterior posterior diameter, and expiratory wheezing. This is likely, this is not asthma, this is COPD. And of course, you get the history that some is chronic, happening for a long time. So if you do your ABG, you are going to definitely see hypoxemia because, oxygen exchange is kind of impaired. I'm going to talk about why all these things happen before I get to the test, because we need to understand that pathophysiology, because they test it a lot in the question stem. We need to understand that pathophysiology of all these hypoxemia and the likes. And they will also have acute or chronic respiratory acidosis. We have said this. The muscles are fatigued, they are tired, so they don't hyperventilate. So they are already having a chronic or acute state of respiratory acidosis. Now, I don't have a picture with me. I thought I would be able to get a picture, but I don't have it. But I'm going to try to explain to us. If there's a way I can draw, I don't know if there's a way I can draw. I think we used to draw with the drawing too. I don't know if I can draw something here. So now we need to understand what really happens in people with COPD. What happens is that they have problem getting air out during expiration. There is air trapping. At the end of the day, you have a lot of pressure within the alveoli, and that is what you call the extrinsic or the external, should I call it, just say extrinsic PEEP. So that's the peak expiratory end pressure. So because there's a lot of air, so let's say this is the alveoli here leading to the airway. This is the airway hub. So you have air gases, everywhere like this, like that, trapped in the alveoli, and they cannot get out. They will keep pulling up here, and you have PEEP. So don't forget, the diaphragm is already here, right? Convex like this. This is the normal shape of the diaphragm. The convexity of this diaphragm even allows it in its action. So it can allow for easy distension, easy distension of the diaphragm during inspiration, because diaphragm is a major inspiratory muscle. That's a primary inspiratory muscle, diaphragm. Once it's gone, the person is going to have serious difficulty taking in air. So, but in people with COPD, where you have a lot of air being trapped like this, you have a lot of pressure on this diaphragm. So what is going to happen to this diaphragm? The diaphragm is going to appear flattened, right? So it will appear flattened like that. And in this flattened stage of fate or appearance, this flattening form, the diaphragm cannot contract effectively. Now, normally during inspiration, if the diaphragm is convex like this, it can contract, come down, and create like a suction. It creates a negative pressure for air to come in during inspiration. But once you have airway trapping due to COPD, and you have compression of the diaphragm, loss of the convexity, flattening of the diaphragm cannot contract. So it cannot generate a negative pressure to overcome the pressure that is there to suck in air. So definitely the person is going to be having inspiratory difficulty, and they cannot get in air. And the air that they are getting in, what does it contain majorly? Oxygen. So definitely that person is going to be hypoxemic from there. And what do you think will happen to CO2? CO2 will keep accumulating because that is what is trapped there. That is what is supposed to get out, but it will keep accumulating. So what do you want to do? Sometimes you might want to administer a positive pressure, so that positive pressure is going to come from external, from outwards, come down like this, bam, and widen this airway. So that we call that the intrinsic PEEP. So you bring it out. So you bring it from outside, like from a machine. So sorry, I think I've mixed up the terminology. The one you are bringing from outside should be the external PEEP or extrinsic PEEP. The one that is inside should be the intrinsic PEEP. Whatever the nomenclature for, it's just understanding the pathophysiology that is important. Forget about the naming. But you shall bring out an external pressure from your machine. It can be from your CPAP, it can be from your BiPAP, it can be from your mechanical ventilator. I'm going to talk about them. And they will deliver a positive pressure at the end of expiration But most of the time we use the BiPAP because BiPAP will deliver the pressure both at inspiration and expiration. And the one for the expiration will, kind of widen this airway so that this air be able to get out. And the inspiration is going to still keep it widening so that air can move in, containing oxygen to take care of the hypoxemia. So the extrinsic pressure is helping to allow air to get out during expiration, reducing the PaCO2, while the intrinsic PEEP is coming in to keep the airway open so that oxygen can come in and there will be diffusion. So the difficulty in this relaxation of this diaphragm prevent generation of this inward negative pressure to bring in air. So in that situation, the body will want to recruit other accessory muscles to breathe. That's why you see use of accessory chest muscles. They want to use muscles like serratus anterior, latissimus dorsi, your sternocleidomastoid, to try and assist with creating that negative pressure so that you can breathe. But they can't work as much as your diaphragm. So do we have a clear picture of what is happening? By the time I start showing us questions, we'll know what to pick. Do we understand? Or I should come again with, I'm sorry about the sketch.
Yeah. So where is it extrinsic coming? I know now intrinsic is in, extrinsic is out. So, but
Yeah.
where
You are
is
giving it,
extrinsic? Where?
you are getting
Yeah.
it from your machine. That's why I said
Okay.
either you are using a
Is it in?
BiPAP,
Okay.
there's a BiPAP machine,
Okay.
biphasic positive pressure machine. It delivers positive pressure both in inspiration and expiration, or you use a mechanical ventilator. Don't worry,
Okay.
we'll get. I just want to expose you guys to that. By the time we start looking at
Doctor,
treatment,
you
So the
mind just
extrinsic
summarize
one,
everything?
the string, where is the extrinsic one coming from? From machine too?
no. The one that is here is the intrinsic PEEP. That is what is compressing on the diaphragm, causing the problem.
Okay.
So you now want to overcome that by giving an extrinsic that will open this airway so that all this gas can move out.
Okay. Oh, okay. So the
So,
extrinsic is like not like normal breathing. So the extrinsic comes from your machine to allow air to be moved out, right?
Yes. Do you
Okay.
get it? Usually during expiration, because this air is trapping in expiration. So you need to
Mhm.
give an end expiratory
Then,
peak pressure to open that airway so that you can have the gas moving out. But you also need to keep it open too in inspiration so that oxygen can move in.
okay.
So that's why
so what?
preferably,
Okay.
Sorry, doctor, but I wanted you to summarize it in 2 words. What's the rationale? Is it just to reduce, or rather, what I assume is that the air is so much when it's collapsing on the diaphragm, it's not able to contract and relax, something like that. So when you open the airway, the when you open the airway, basically what happens is they're able to contract and relax, like the air begin to, like, say, float properly back and forth on the diaphragm. Is that the aim?
no, not really. You see, that relaxation part is what is not really there. Because
Okay,
what you are trying to do is that you are trying to assist the diaphragm with inspiration. The diaphragm is a primary inspiratory muscle, and
correct.
the way diaphragm helps in inspiration is by contracting, not by relaxing. The diaphragm
Okay.
contracts, moves downwards, and creates a negative pressure. And
Mm-hmm.
here is going to move from positive to a negative pressure. But what is preventing that diaphragm from contracting ab initio? It is due to what? Air trapping in this COPD. Air is trapped here. They are numerous. They are compressing on this diaphragm. Diaphragm is flattened. Diaphragm cannot contract. You know that already there's a lot of CO2 accumulating here, right? So PaCO2 is already elevated. What will happen to oxygen? What can help us take in oxygen is diaphragm contracting so that I can create a negative pressure and you can take in oxygen, right? But if CO2 is accumulating here and compressing on the diaphragm will not be able to contract. You cannot take in oxygen. Inspiration too will be affected. So the person will be hypoxemic. So what do you do to solve these two problems? Give a BiPAP. BiPAP delivers positive pressure put in inspiration and expiration. So expiration first to take care of the starting problem. You deliver a positive pressure at expiration to keep this airway open, patent, so that all this gas, CO2 that is accumulating here, will move out. When they move out, what do you think will happen to the diaphragm? Diaphragm will now kind of achieve its normal form. It becomes less flattened and more convex, so that the diaphragm can contract and bring out air, and bring in air rather, contract, create a negative pressure, and bring in air during inspiration.
It's like when this process of preventing atelectasis, creating of intrapleural pressure, something like that.
Not really.
Ugh.
We are not really creating. Well, it can affect the intrapleural, but the intrapleural pressure is on its own. That one is like -5.
Mm.
That one is, you are not really, disturbing this guy that is outside. Intrapleural is outside here. It is what is inside here,
That you're
that
worried about. Okay,
you are altering.
okay.
So
Makes sense.
you apply this airway pressure down, keep this airway patent, so that at expiration, gas move out. Less gas here, diaphragm will not be flattened again. Diaphragm can contract well, generate a negative pressure, so that you can allow air to move in and correct hypoxemia. And when the air have escaped initially by you generating a positive pressure here initially when you delivered, CO2 will have moved out too. So definitely you have corrected the PCO2, and at the same time you have also corrected the hypoxemia.
All right. Thank you. That's really helpful. Thank you.
So you can also do gram stain and culture to identify whatever bacterial is causing that exacerbation. Sometimes you can have exacerbation. So, although it's not necessary to do this gram stain and culture, honestly, because the bacterial load does not correlate with the degree of inflammation. You can have 1 million bacterial load and inflammation is small. You can have 2 bacteria and inflammation is wide. So you don't even need to be disturbing yourself, to be quantifying, to be worried. So you don't need to do your culture. You only give antibiotics when you notice some particular findings, which I'm going to show us. There's prolonged sputum production, increased sputum production, increased dyspnea. Once you have any two of that, you give your antibiotics without doing your gram stain and culture. It is waste of time. So um, there's some stuff that we need to know that increase survival in individuals with COPD. We cannot go for our exam and not know interventions that improve survival in people with COPD. The two major ones, supplemental oxygen, but we no go overshoot them, because you remember it's going to ablate the respiratory drive, worsening hypercapnia. So you actually, it's for people with what's it called, stable COPD, not on exacerbation like that. So people with stable, what they are talking about here for survivor is people with stable COPD. So, and they have SpO2 less than 88. So you might want to keep it between like maybe 88 to 92. Long-term home oxygen therapy. I'm going to talk about it. And smoking cessation. So you want to tell them to stop smoking. Another thing is you have to give them their vaccination, particularly influenza. Then you also encourage pulmonary rehabilitation. So those 4 things I'm going to show us, so we see them very well. Long-term home oxygen therapy, smoking cessation, pulmonary rehabilitation, annual influenza vaccination. Those are the things that can promote survival, long-term survival in people with COPD. So
Dr.
somebody comes in.
Papa, yeah.
Yes,
Sorry.
Dr.
You
Antonio.
said something about antibiotics. You said once you have fever, productive cough,
Yeah,
you
yeah,
go ahead
I
with
get it.
antibiotics
Don't worry,
or from
don't worry,
from
don't worry.
bronchitis.
I will say it again. You will see where I will say it. Don't worry. I will say it.
Oh,
Don't worry.
okay.
So, um, diagnosis, somebody having COPD like picture, you want to do your spirometry, right? Best initial test to confirm what you are dealing with, and you are going to see an obstructive pattern that is not reversible with your server. Once you see this, you know that this is definitely COPD. it is not reversible. It's SABA, and you're having this obstructive pattern. Although I expect somebody to checkmate me that maybe you can see this in bronchiectasis, so that's why you are not going to stop here. So the other things that we are going to see again, the FEV1 over FVC is going to be less than 70. Please, we need to pay attention here. FEV1 is less than 80. You can have a normal or reduced FVC. Of course, that's why the ratio is less than 72. So FVC, but the most important thing is just to know that this ratio is less than 70. That's that. And paying attention to your RV and your TLC. This is a condition that causes airway trapping, air trapping, and hyperinflation. So you are going to have an increase in the functional residual capacity, increase in the residual volume, increase in the total lung capacity at the head. Of course, those are the causes of the increased anterior-posterior diameter. So once you do your spirometry and you give your SABA, you are not going to see improvement of 12%. If there's improvement, it's going to be less than 12%. That's it. So don't fall into that trap. They can show improvement of maybe like 9. Some people think, maybe don't improve. That's asthma now. No. If it's not up to 12%, please don't pick what's it called? If it's not up to 12%, don't pick asthma. If it's 12% and more, okay. 12% and more improvement, that is asthma. But if it's 12%, less than 12%, that is COPD. So what else again? Do they usually put there to narrow down the diagnosis? You look at the DLCO. After you have seen the FVC less than 70%, the ratio, you have seen your RV increase, your total lung capacity increased, you have seen that, okay, the change after you have done your SABA is less than 12%, the improvement is less than 12%, okay, you know that this is COPD. But what type of COPD? Is it chronic bronchitis or asthma? So, because of the fact that chronic bronchitis just affect the airway, the alveoli is kind of spared, they will have normal DFCO. They will have normal DFCO. But emphysema destroys the alveoli, respiratory bronchus. That respiratory membrane is gone. So there's no spot for our carbon monoxide to diffuse into the blood. So people with emphysema definitely will have low DLCO. So that's one way you can separate between emphysema and chronic bronchitis. Chronic bronchitis will have normal DLCO, emphysema have reduced DLCO. So this is the question we answered. Dr. Joy answered. The patient will also benefit from inhaled corticosteroid with a long-acting beta-2 agonist. So what are the X-ray features of individuals with COPD? Don't forget the initial test spirometry. The next, you can do your X-ray. So hyperinflated lungs. Yes, just like what you see in asthma. Because of the hyperinflation, it's going to obscure, the vessels. Lung marking, everything is going to reduce. Because of that hyperinflation, it's going to compress on the diaphragm, and convexity of the diaphragm is going to be lost. This one is not very flattened like that, but it's already getting flattened. So you notice flattening of the diaphragm, and we have said that all this problem usually comes from diaphragmatic flattening. The one I've explained comes from diaphragmatic flattening. So because of the fact that the lungs are hyperinflated, they kind of pull down on the mediastinum. So you notice that the mediastinum looks narrow. You see narrowing of the mediastinum. Now, because of this hyperinflated lung, again, a lot of air here. Those air can be tracking along the tissue plane of the lungs, and they can be collecting in small pockets. So some of them can collect within the pleura surrounding the lungs, forming subpleural plebs. Some of the air can collect within the lung parenchyma itself, forming bullae. So you don't see bullae in the pleura. Air pocket in the pleura is called subpleural plebs. Air pocket in the lung tissue is called outside the alveoli, between the interstitial. We call that bullae. That is why COPD is a risk factor for pneumothorax. You can have rupture of this bullae, rupture of these plebs, and you can have air seeping into the pleural cavity, causing pneumothorax. So
Sorry,
hyperinflated lungs.
question.
Okay, I will take it. Normally, I'm not supposed to take any question until we finish the stuff. But let me hear your question, Doc.
But the truth of the matter is, Momo, that we understand more when we ask that question. As you go,
But but but
into the,
I'm going to be
no,
distracted. There are things I will
yeah,
forget to say.
it's
That is
true,
it.
sure.
Okay, I'm
But
listening. So, what is the question?
Okay, thank you. I just want to confirm if this chest X-ray findings, like, how do you differentiate it from that seen in asthma? Because of the hyperinflation, the narrowing of the
Yeah, that
mediastinum,
is it. That is
flattening of
it.
the.
If you notice what I'm saying that just like you see in asthma, you know, asthma will also have hyperinflation. You can't differentiate hyperinflation of asthma from COPD. It is the same thing. But people in asthma might not typically have increased anterior posterior diameter. They may have if it's very severe, but it's very, very common with people with COPD. And of course, from your symptomatology, you will know that this is not asthma you are dealing with. Exertional dyspnea, dry cough, no chest tightness. The age, they will tell you the person is smoking. You know that it is likely to be, COPD and not asthma. So what is going to help you majorly is your clinical presentation, not your X-ray.
Okay, so can you show that anterior posterior diameter I talked about on this X-ray?
This is it. This is it here. So the anterior posterior diameter is increased here. You can see the barrel. You can see the way it's appearing. You can see that convexity. So this is what you see. Once you see a typical X-ray like this, you know, you know that it is anterior posterior diameter they are trying to tilt you towards. You don't even have to measure. You don't have to look at it too much. Once you see something looking like this, barrel, you know, this convexity like this, that is, COPD they are trying to tilt your mind towards. So um, then the treatment. So the treatment occurs in two forms. So exacerbation and stable. So we are going to start with the exacerbation first. And what I want to say is that the algorithm for acute exacerbation is the same as the algorithm for asthma. If we remember what I said yesterday, you want to maximize the expiratory flow. That's number one thing. You want to reduce the airway inflammation. That's number two. You want to increase oxygenation. That's number three. And if there's a need, you want to ventilate that individual. So what does exacerbation means? Somebody that is having stable form of COPD initially, suddenly develops cough, increasing cough, increasing difficulty in breathing, or increasing volume of sputum production, or changes in the sputum. Maybe sputum is having some purulent coloration, or maybe some abnormal color. You know that, okay, maybe this person had some bacterial infection or viral infection that is causing, worsening of the symptoms. So that's what we call exacerbation. Changes in any of these parameters. Either the cough gets worsened, there's dyspnea, or there's changes in the volume or the character of the sputum. So what do you want to do? You want to maximize expiratory flow, right? And what do? You have to give your inhaled bronchodilator. So you give your SABA or your ipratropium, or you can combine them depending on the severity. So SABA or SAMA, please. That's what you are going to use. Short, rapidly acting bronchodilators. Those are the stuff that is going to help you maximize the respiratory flow. We know that this is an inflammatory event. It's either due to maybe a bacterial infection or a viral infection. So you want to reduce that inflammation. So you must give systemic corticosteroids. So most of the time you use IV prednisolone. Give your IV prednisolone. If they cannot swallow IV prednisolone to reduce that inflammation. Now, before we get to oxygenation, some of them might require antibiotics. And that is where you have any two of more of these symptoms. The person is having dyspnea that is increasing, cough, or the person is having cough and increased sputum production, or the person is having increased sputum production and dyspnea. Once you are able to identify any two of these, you must add an antibiotic to that treatment without you doing any gram staining or culture. Give your antibiotics to treat that. Then sometimes, of course, you have to oxygenate that person. If the SpO2 is less than 88%, you have to give supplemental oxygen, titrating it to what? 88 to 92. Don't take it beyond this. 88 to 92. Now, if the person is now having a very severe form, and I told us those severe symptoms yesterday, either the person is having hypoxemia less than 50, hypercapnia more than 50, the person is having altered sensorium, confusion, agitation, you know that definitely this person is gradually tilting towards respiratory failure. And before the respiratory failure sets in totally, you have to rescue and take over that breathing. So before you take over the breathing, there's something we do. So we call it like a bridge to the recovery now. So there's something we call the non-invasive positive pressure ventilation with bi-level positive airway pressure. Please forget about the big names. What they are just saying, non-invasive, meaning you are not going inside the airway, like putting a tube inside the airway, like you do for endotracheal intubation, for mechanical ventilation. No, you are not doing tracheostomy. No. What you are doing is that you are getting a machine and you are connecting a nose mask or a fixed mask to that machine to deliver pressure. You have two types of that machine, a CPAP and a BiPAP. The difference between CPAP is continuous, while BiPAP is bi-level. Most of the time, your CPAP delivers pressure only at the end of expiration. Mind you, your patient is the one that is breathing on his or her own. Person is the person that is breathing. You are just assisting by delivering a pressure at expiration. That's your CPAP. But for bi-level positive airway pressure, you are delivering pressure while the patient is breathing on his or her own. You are delivering pressure, positive airway pressure at inspiration and expiration. Why are you doing all these things? Because of those things we talked about when we were drawing. So the one that we typically use to rescue someone that has COPD, tilting towards respiratory failure, is your BiPAP, the one that will deliver the pressure both in expiration and inspiration. Deliver the positive pressure in expiration first, so that the air that is trapped at the end of expiration can move out. The CO2 that is there can move out. What is going to happen to CO2 level is going to drop to normal. There's relief of hypercapnia. When CO2 moves out, there's less intrinsic PEEP compressing on the diaphragm. Diaphragm can contract adequately. When diaphragm contract adequately, it creates a negative pressure so that you can now take in air. Now, when you are now trying to take in air during inspiration, you are already delivering another positive inspiratory pressure to keep it open very well so that oxygen can diffuse in and get into the blood and prevent hypoxemia. So this is very, very good. But mind you, this is if the patient has the ability to even be doing ventilation. So you only have to do this for 2 hours. If this fails within 2 hours, you stop whatever you are doing with your BiPAP person and you mechanically ventilate that patient by taking over that airway completely and you put the patient on the machine. So in that instance, you are going to put an endotracheal tube into the airway, the trachea, and you connect the stuff to the machine, and the machine will deliver the pressure as well as control the breathing. That is if your NPP fails within 2 hours. But there are some conditions that might not even allow you to use NPPV ab initio, which is number one, if this person has increased secretion, because you're only applying face masks, you are not connecting any tube into the airway. So there's no way the person can handle secretion. The person can easily aspirate. That's one of the side effects of BiPAP. It doesn't protect against secretion, but your endotracheal intubation can allow you protect against aspiration of secretion. If this person has facial trauma or burns, you can't be applying masks to someone that has burns on the face. You can't use it. It's not going to seal. If this person has a very high risk of aspiration, particularly people that have lost consciousness, you can't use NPPV in them because they don't have control over the glottis again. They can easily aspirate and die. So there are contraindications. In the absence of this, you might want to try your NPPV before you now do endotracheal intubation. Do we understand?
Sorry, please, I
this
didn't,
part
I
already?
didn't get the other one. Aside the BPAP, the other one I talked about.
The CPAP.
Is it CPAP? Yeah.
So I said CPAP is continuous positive airway pressure that delivers positive pressure only at the end of expiration. It delivers it only at expiration so that you can have escape of the gas at expiration, but it doesn't deliver at inspiration. The one that delivers at inspiration is the bilevel positive airway pressure, which is your BiPAP. Dr.
So are there
Anthony,
times you want to use the CPAP?
are there times you want to use it?
The CPAP
No,
versus,
no,
like
no,
you said, for
no,
COPD, you want to use
no, no,
BPAP.
no, no. The best to use for COPD initially is your BiPAP, helping both in inspiration and expiration. You use CPAP in obstructive sleep apnea that we are going to talk about later. Dr. Antonia, is it clear to you? Or you have a question to ask me?
Yes. No, it's there. Yes.
Dr. Joy, do you get it?
Very clear. Thank you, Dr. Bawale.
I don't know if Dr.
So,
Oluranti is
but
here.
would you not call this intubation like invasive CPV or
Yes,
something?
intubation
Okay.
is invasive. Intubation is invasive because you are going into the airway. So that is invasive. It's no longer non-invasive, it's invasive. So once you intubate, you have invaded into the person's airway. So, but you know that intubation is not easy. Don't be easy stuff. Even when anesthetic go dey battle the thing. So that's why you might want to try easy stuffs like your non-invasive procedure first. Then if you can't get any help with that, you progress to your endotracheal intubation. So don't forget the trial of 2 hours with your NPPV first. And don't forget to check if there's a need for antibiotics. They can test that in the question step. So let's go to the chronic COPD. So someone that is stable, the person no get any exacerbation like this. What do you want to do to prevent the person having exacerbation?
Okay. So sorry, Dr. Babawale. So this NPPV, do you do it together with the bilevel?
No, NPPV
Or
is a form.
or you
BiPAP
just
is a form of NPPV.
okay. All right.
BiPAP is a NPPV means non-invasive positive pressure
Positive
ventilation.
pressure, yeah. With okay, so this is a form of it. Okay.
So that's a form. So so chronic COPD, the person is stable, just having occasional dyspnea, maybe when the person walks for a long time. But at rest, the person is calm. So what do you want to do for this kind of individual? You want to try to help that person, to prevent future exacerbation, number one. And at the same time, you want to, uh, um, you know, increase the chance of survival. That is, it's not all the intervention that you are doing that increase chance of survival. It's just like heart failure drugs. I know that we remember all those drugs in heart failure that increase survival. It is not everything. You are giving furosemide just symptomatic relief. Yeah, you have some other one that helps you survive. So the same thing happens here in COPD. So the first thing is that if this person is smoking, you tell the person to stop. You know that smoking can cause both emphysema and chronic bronchitis. So you tell the person to stop smoking. Very, very important. Then the next thing is encourage vaccination. So you want to vaccinate the person against 2 major organisms. These 2 organisms have been notorious to increase mortality rate in people with COPD. and that is pneumococcal and your influenza, pneumococcal and influenza. Most of the time, you only give your pneumococcal once. You might not need booster. Just give it once. So you can give the conjugate alone. The conjugate PCV20, that is 20 minutes is covering against 20 serotypes. Or you can give the PCV15 with this one, which is the non-conjugated one, PPSV 23. You can combine it with the 15, or you give the 20 alone, whichever one that you have. So you give it in individuals that are beyond the age of 19 years. So you have to give them your pneumococcal vaccine. Very important. PCV 20 alone, or PCV 15 with your PPSV. All ages, not more than 90 years, all ages with COPD, you give annual influenza vaccine. This one with smoking, both of them increase your chance of survival. Influenza vaccination annually, smoking. Now, we are going to talk about the algorithm. So there's the GINA, no, is it GINA? No, not GINA, GOLD algorithm to, guide on how we use our inhalers, our bronchodilators in people with COPD. We are going to look at them very soon. So let's just keep that. Let's still remember the lifestyle modification, smoking, and the vaccination. Now, long-term oxygen therapy. This is very important in people with stable. Please don't fall for it. People with stable. Those are the people you give long-term home oxygen therapy. They will take it home. That machine is for home. So it continues to deliver oxygen for at least 15 hours. So it kind of helps them. But you don't give it to all patients though. You don't give it to all patients so that you don't tilt them into hypercapnia. So you give it only to patients that have SpO2 less than 88 that is stable, or arterial oxygen concentration of less than 55. But there are some other conditions that you have a lower threshold of administering it. Anybody that have developed pulmonary or right heart failure and polycythemia. We know that hypoxemia, chronic hypoxemia can cause polycythemia. We remember hypoxia will trigger release of erythropoietin. Erythropoietin will cause polycythemia, right? We know that if there is hypoxemia, you can have pulmonary vasoconstriction, increase after load in the right side. Right ventricular contraction will be affected, right ventricular remodeling and the likes, leading to right heart failure at the end of the day. So in that kind of person, you will not wait for their SpO2 to be decreasing to 88. You have a minimal threshold in them. So their own threshold is 89. So when the SpO2 is 89 or less, or their PCO2 is 59, that's when you give them long-term oxygen therapy, take home. So normal person, SpO2 is less than 88 or PaO2 is 55. People that have polycythemia or pulmonary, when their PaCO2 is less than 59, SpO2 is less than 89%. And what is your saturation goal? 90 to 93%. We don't need to cram it. Nobody will really ask us. Just know that it's more than 89. And just add maybe like 3 or 4. If you check your UWorld, you'll be seeing 90 to 94. Check other textbook, you can see 90 to 94. So 90 to 94, 90 to 93, same thing. It's okay. Just keep it above 89. So that's your target. And long-term therapy improves chances of survival. Oxygen improves chances of survival. Influenza vaccination improves chances of survival. Then lastly, pulmonary rehabilitation. So something we call pulmonary rehabilitation. I have written it out, so I'm going to show you. So this is more like a summary. All patients, tell them to stop smoking. You give them their pneumococcal vaccine, your PCV20 alone, or PCV15 plus PPSV23, your annual influenza vaccine. Then, of course, if the person has chronic hypoxemia, you want to give your long-term oxygen therapy, maintaining it to 90 to 93 or 94. If it is less than 88%, or if PaO2 is less than 55 in normal, or in somebody with pulmonary or polycythemia if the PaO2 is less than 59 and SpO2 is less than 89. Then pulmonary rehabilitation. So what do we mean pulmonary rehabilitation? Let me show us what it involves. So just like a supervised program, you are trying to increase the vitality of people with COPD because most of them, they are tired, they are dyspneic, they are fatigued, they are, so their muscles are weak. So the first thing is that you want to do a supervised exercise training so that you can increase their muscle mass and efficiency of the muscle and their vital capacity, their exercise capacity will be increased. Although it does not increase, it doesn't change lung function, but just reduce reconditioning of the muscle. So the muscle will be up and they can, have some exercise tolerance. The second is education. So education is very important. You educate them, and what are you teaching them? How to use their inhaler, because they also use drugs, and I'm going to talk about the drug very soon. You tell them how to use their inhaler. You teach them the pulse lip breathing, particularly people with emphysema, how they can do it more efficiently, that can increase the airway pressure and allow gas to move out during expiration. Because once gas can move out effectively during expiration, you have solved their problem, because their problem is respiratory block. So you teach them the pulse lip breathing, they are able to maximize the airway pressure at the end of expiration, taking out the gas, preventing flattening of diaphragm. They'll be okay. You counsel them on going for their vaccination, the annual vaccine that they take, which is the influenza vaccine. Action planning. Anytime they notice any change in symptoms, like coughing, producing excessive sputum, to tell them quickly go to the hospital and see a doctor. Education. So nutritional intervention. We are creating a dietary plan to take care of their nutritional comorbidity, because some of them can have obesity, some of them can have people with you remember people with chronic bronchitis, they are big. So you want to anybody that is big, maybe although that big is actually due to fluid retention, but some of them can have superimposed obesity with it. So tell them to watch their weight. Some of them can have comorbidities like diabetes. You don't want to be managing two chronic symptoms, two chronic diseases at the same time. So encourage adequate glycemic control with nutrition and psychosocial support. Somebody experiencing all these kind of things can be very tiring. You might want to give up on life. So you want to, create psychological support, for depression, anxiety, that they want to die. Some of them might have financial constraints, to, do maybe social work kind of a thing that we do in our hospitals. And, some of them might be battling smoking cessation, psychological therapy, to you kind of bring them together with similar people having similar condition so that they can interact, then devise a plan on how to stop the addiction and improve their lives. So usually do it over a period of 12 weeks. So that's pulmonary rehabilitation. Pulmonary rehabilitation is very, very important to increase the chance of long-term survival. Now, people with COPD also use drugs, your LABA, your LAMA, your ICS, but there's an algorithm. You have to ask some questions before you can know what kind of drug you are going to give them. Now, there's something we call the CAT list. So that's the COPD assessment test. It has some questions and some scores. We are not expected to calculate that. If they want to test the algorithm, they are going to give us the CAT value. They're going to tell us, is it more than 10 or less than 10? So if it's more than 10, more than or equal to 10, it is bad. Sorry, excuse me. I want to plug my computer. So you get the value more than 10 or equal to 10, that is bad. If it's less than 10, it is fine. So you get that CAT score from the symptoms. Then the next thing is you want to get the number of exacerbation. It is very, very important. How many exacerbations have they had in a year? Have they had one? If it's one, it is good. If it's two above, it is bad. That's one. So the bad category is if they have had two and above. The good category if it's one or less. Another thing that can place them in the bad category with respect to exacerbation is if they have one exacerbation, but that exacerbation made them land in the hospital, it is bad. So this is what you are going to marry. Now, I'm pleased to tell you that what you are seeing here, this algorithm is archaic. So there's a new algorithm, the gold algorithm here, that has been simplified. So this 2023 updated version, very easy. So instead of having group A, B, C, D, E, just like we have previously, now we have group A, B, and E. Group A, B, and E. Now, let us look at what is on the right side. So on the right side, if you have your CAT score of 10 and above, the person is going to be placed in group B. If your CAT score is less than 10, it is group A. Now, to be in group A and group B, your exacerbation must not be bad. So just look at the word E. E is for exacerbation. Anybody that has exacerbation of more than 2 should be in the worst exacerbation category, which is group E from the word letter E, exacerbation, worse. So 2 exacerbation and above, automatically, irregardless of their CAS score, put them in E. If they have 1 exacerbation but requires hospitalization, put them in E. It is the same thing as having 2 and above. Now, if none of this is fulfilled, they don't have 2 exacerbation and they only have 1 exacerbation and they did not land in the hospital, so they will be in group A or B. So what will now differentiate A or B is now your CAT score. So if they have CAT score of 10 and above, you put them in B. If they have a CAT score of less than 10, you put them in A. So what do you do for someone that falls in group A? You just give a short-acting bronchodilator. You can give SAMA, you can give SABA. Group A. You can give SAMA, you can give SABA. Now, if the person falls into group B, it's the same thing as group E. Both of them, they have to take a LABA with a LAMA. The LABA is going to help with bronchoconstriction. The LAMA usually helps with bronchial secretion. That's just chipping in. It's not really very important. You know that, just know it for knowledge sake. So your muscarinic antagonist typically helps to handle secretion, while your your LABA will kind of help you with your bronchoconstriction. But don't forget, both of them helps with bronchoconstriction too. Now for group E, it is still same LABA plus LAMA. It is only group A that is SABA or SAMA. Other ones you have to add them together, LABA plus LAMA. So group E2, they are taking LABA plus LAMA. But you might not really use ICS in stable COPD unless the person has eosinophil count of more than 300. So anybody with eosinophil count of more than 300, maybe there's an asthmatic overlap or something, and that is causing the eosinophilia, you might want to introduce ICS. But mind you, you don't use ICS if the person has history of recurrent pneumonia from any cause. Recurrent pneumonia from any cause, you don't put ICS. You don't do it. You leave it. So, but I'm sure they might not really get to that level. But just know that the only indication for you to add ICS in group E is if the person has maybe asthmatic overlap and the person is having eosinophil count of more than 300. So, do you understand this algorithm? Is it clear to us?
Doctor, but why don't you give ICS in patients with what
Recurrent
they call
pneumonia.
recurrent
Steroid is going to suppress the
inflammation?
immunity and it will worsen the pneumonia.
Okay.
So,
Neutrophil.
so that is all about. Let me just see if you can solve. I think we have plenty question for this COPD. There's plenty question here. So let me see. Let me start from here. Okay, I have one here. Oh, there are plenty. So let me
Sorry,
correct you.
I also had a question on what makes up the CAT score, please. Maybe I missed it.
Yeah, I said it's just the symptoms. We are not the one that will calculate it. Do you understand, Doc?
Okay, so the more the number, the more severe.
Yes. So if it's 10 and beyond, 10 beyond, the person is in a bad shape, so you might want to put the person in category B. If it's less than 10, category A. But if the person has two exacerbation, the guardian of the CAT score is group E. If the person has one exacerbation but requires hospitalization, put in group E, regarding of the CAT score. Do you get that?
Yes.
Sorry, Dr. Joy, I don't know. I'm battling with this thing to Zoom to enlighten
Fine, it's
maybe
fine.
because
We can manage. Fine, we can manage. Don't stress. We can manage.
okay, sorry about
Antonia,
that.
hope you can say sorry.
I can't expand this. So a
I'm
71-year-old man.
not seeing anything at all.
Let me see if I can
This one is like
let me see if I can kind of bring down this shrink. What about now? Does it help? Dr. Antonia, can you see it now?
hello.
Dr. Bawo, the part they wrote, if you touch, no, it's fine. If you touch
I
the
can,
lower part,
I can manage.
yeah,
It's I'm only
yeah,
I'm
there,
just very
125. Can't you increase it from there?
Oh, sorry, I didn't see that. That's true.
Yeah, 150 is fine, I think. On
I think that's affecting the page at the
okay.
back.
no, okay, makes sense.
Yes,
Come on, we can manage. We can manage. Yeah, it's fine.
Okay,
yeah.
so a 71-year-old man with severe chronic obstructive disease comes to the office due to worsening exertional dyspnea. So, worsening exertional dyspnea and fatigue. The patient takes a combination of bilanterol, umeclidinium, fluticasone, inhaler as prescribed, but still becomes winded with light activity, such as trying to tie shoes, taking a shower, cooking. Is reluctant to perform even minimal exertion because it provokes his dyspnea, triggers anxiety, leaving him feeling wiped out for the remainder of the day. The patient reports daily cough but minimal sputum production. He has required outpatient antibiotics and oral corticosteroids on 2 occasions for acute exacerbation. A recent low-dose screening CT scan of the chest showed extensive emphysema and hyperinflation with no suspicious nodule. The patient has a 60-pack-year history but quit smoking 10 years ago. Blood pressure is 130, pulse is 80, regular respiration is 20, pulse oximetry shows 95% in room air. BMI is 19. After walking for 6 minutes as at his usual pace, his oxygen saturation on room air is 92. Which of the following is most strongly indicated to improve this patient's ability to perform daily activities and reduce his risk of COPD-related hospitalization?
Yeah, strongest indicator to improve the ability to perform daily activities.
And reduce the risk of COPD-related hospitalization. So what do we think?
So we're looking for anything that'll make it better. Pulmonary, why not rehabilitation?
Yeah, you have to rehabilitate this person.
Let me
This
see.
is like someone that has a stable COPD. You know, you agree with this is stable COPD because the person was having the symptoms after walking. It's not as if the person is acutely having dyspnea, cough, and the likes. So the person has
Yeah.
this presentation usually after walking. or after stressing.
Mm-hmm.
So
Mm-hmm.
it means this person has stable COPD. So what you can do for this person is maybe you pulmonary
It is.
rehabilitation, or you give continuous oxygen, right? Or maybe if the person is
Yes.
smoking, you tell the person to stop
Oh,
smoking.
continuous oxygen would have been nice, but he's
Yeah,
I think from here it was 92 somewhere around the vignette. So if it's
exactly.
92, I don't think oxygen
Nice.
would help in this. Yeah, it's
So you don't
92.
need
There's no need
you
of
don't
any
need
oxygen.
you don't need
Yes.
oxygen because it's
Yeah, stopped
92
10 years ago. So the next thing will be more of the pulmonary rehabilitation.
rehabilitation. Okay, so let us look at the next one. A 68-year-old woman with a history of advanced COPD comes to the emergency department due to increased shortness of breath and cough. Increased shortness of breath and cough for 12 hours. She took 2 extra nebulizer treatment at home with no relief of symptoms. She has no fever, nausea, vomiting, or hemoptysis. The patient has been oxygen dependent for the last 2 years. She has a 45 pack year history and quit 6 years ago. Medication includes tiotropium daily, fluticasone salmeterol twice daily, and albuterol by meter dose inhaler or nebulizer as needed. Temperature is 36.7, blood pressure 110, pulse 110, respiration 28. The patient appears dyspneic and in moderate distress. She is given intravenous antibiotics, methylprednisolone, and 2 treatments of nebulized impratropium with albuterol. Following these measures, the patient remains dyspneic and uses accessory muscles of respiration, but is alert and follows command. On 4 liter per minute oxygen, pulse oximetry is 89%. Arterial blood gas shows pH of 7.3, PCO2 of 63, oxygen of 54. Chest X-ray demonstrates hyperinflation. Which of the following is the best next step in the management of these patients?
The patient is having respiratory acidosis already.
Uh,
Yeah,
what's the mental status of this patient?
she's alert.
Okay, that is
That
very
is a
good. That is very good.
she's a
She said
okay.
she's alert, and the fact that the patient is already having respiratory acidosis, you can see 7.30, the
Mhm.
PCO 63, oxygen is hypercapnia and hypoxemia, then the respiratory acidosis. So we should start our guys now. The NIV, the NPV,
Non-invasive. The
The
non-invasive.
non-invasive.
then is
Yes.
not
So
invasive,
you will
yeah.
not immediately go and ventilate mechanically because this patient is
No,
alert. There's no
still
contraindication to
There is nothing. So
NMPV.
now invasive NMPPV will be
I
perfect.
was even looking
Very good.
for so, but it wasn't in option.
What?
Saba or something.
She's
But it's
already
not.
No,
she's on it
she's
already.
It's already on it, right? Okay.
she's already on it.
She's
Tiotropium
on
Okay.
it
So,
already.
yeah,
and
she's already on
then
oxygen, Saba. So the next is the NPPV.
The
yeah,
fact that
they
she's
have even
already
given they are even giving the antibiotics. They are giving the stuff
mm,
to take care of the airway inflammation, metipred. They are
mm,
giving 2 doses of what to take care of expiration, maximize
mm,
Yeah.
respiratory flow, ipratropium, which is our SAMA, and albuterol, which is our SABA. And yet, this person is still
mm.
having problems. So,
She's having severe exacerbation.
uh,
So,
okay, that's
so
good.
Dr. Makwale,
Yes, you
so
can continue.
for long-term management of this patient to improve long-term survival, right? You go
Yes,
through all these lifestyle management, the vaccines, and the
yes.
at-home
The pulmonary
oxygen.
rehabilitation, the
Okay.
pulmonary rehabilitation, the oxygen, the pulmonary rehabilitation, the smoking, and the vaccine. Those ones are constant. But you now check, does he need long-term oxygen? You give if the person needs. Those are the
Mm-hmm.
those are the stuffs.
Yeah.
Those are the first stuffs. So for
Mm-hmm.
stable. So let me see. I don't know if I have anything looking around here. Okay, so a 40-year-old man comes to the office due to exertional dyspnea of 6-month duration. He occasionally expectorates mucous sputum. He has no fever, night sweat, weight loss, or loss of appetite. The patient's past medical history is unremarkable. He is married and has 2 children. The father died of non-alcoholic liver cirrhosis at the age of 58. The patient smoked less than half pack of cigarette daily for 15 years, but stopped after becoming short of breath. He does not use alcohol or recreational drugs. Vital signs are normal and pulse oximetry is 97 on room air. The breath sounds are decreased bilaterally. There are no crackles or wheezes. Lab result is as follows. So albumin 4.2, total bilirubin 1.0, canine phosphatase 96, aspartate and alanine 44.5. Which of the following is the most likely diagnosis?
Alpha 1.
Alpha 1. So very, very
Involvement of lung, involvement of liver, family history of
Family.
liver.
family
And
history.
this one will be more of the central axina or the central part
So
of
which
it.
one is it going to be?
It's
Which of
going
the four
to
is going to be?
If it is alpha 1, then it is Panacina.
It is
no,
panicina.
the
It is
patient
panicina.
smoke. This
It's
one, the
Panacina.
patient smokes.
No.
It's,
You know, we said it. We said it that they can smoke there. It will not be significant like that. Half pack. If you calculate the pack here, it's not going to be
Yeah,
significant.
for 15 years was
So,
smoked. Okay, and he
so that
stopped.
and it stopped. Yeah, it stopped.
Mm,
And
yeah.
of course, since you are picking, uh, what's it called?
family is already.
Alpha 1 already. So that means you are taking out smoking. You are saying alpha 1 is a
Mm,
problem.
Yeah.
So
Yes.
it's going to be panicina.
Mhm.
Okay, I think that's the only one I have here. Uh, okay. I think maybe we check our U-word,
Mm-hmm.
be able to see more questions there on COPD. There are a lot of COPD questions. They are not okay. Yeah, these are that one. A 60-year-old man comes to the office due to shortness of breath over the past 5 months. He also has chronic cough that is more pronounced in the morning, productive of whitish sputum. The patient's shortness of breath initially occurred with heavy exertion, but now experiences dyspnea with daily task. He has no fever, chills, hemoptysis, chest pain, or topnia. Medical history includes this: hypertension, BPH, depression. The patient has smoked cigarette for the past 40 years and has recently reduced his consumption from 1 pack to half pack per day. The temperature is 37, blood pressure is high, pulse 78, respiratory 18, pulse oximetry 96 and 92 after a short brisk walk. BMI is 18. Examination shows a thin man in no respiratory distress. Breath sounds are mildly decreased throughout. Spirometry as follows: PEV1 75, PVVC 57, total lung capacity 104, residual volume 132, diffusion capacity 68, normal greater than 80. No significant change is noted after administration of albuterol. Um, Complete current is normal. Which of one is the most effective measure to decrease mortality in these patients? Oh, this one will be.
He's having emphysema because of
Yeah,
the
Mm.
exactly.
fact that he's thin.
Thin,
BMI is 18.
a
It's
thin
thin.
man.
And what else again? What else again is
See
supporting emphysema?
the DLC or that
Diffusion capacity is normal.
yeah, the
Exactly.
diffusion capacity is low. Is
The
low.
It's low.
diaphragm is low,
It's low.
68.
Yeah. Yeah.
So
It's
that
low.
will
Yeah.
be emphysema.
It's
So
greater than.
Let him
means
stop
means
smoking. We'll stop smoking. Let's hear something.
yeah. So
He
we'll
said
tell the
he
person to
stopped.
smoke.
Did you say
He
he
has not
stopped?
stopped though. He has
He
not
has. Yeah. He has to
He
stop
has not stopped.
smoking.
He has reduced to half. So we have to tell him to stop it at the half self to don't
Let's
take care
start
of the
with
family.
stopping first.
To take care of the smoking. I think that's everything we have. So we'll continue tomorrow again
Thank you
and
so much,
look at
Dr. I mean, This thing
You are
they
welcome.
confuse you, but
You are welcome. By the time you go back,